Hello guys, I'm back with a new topic and most importantly the newer guidelines which are coming all the way. So in the ever-changing environment, in the ever-changing medical scenario, there has come the new guidelines of management of stroke. I'll assure you that most of the guidelines are the same, but there has been a very minute and major changes in the recent guidelines, and which are very, very important. We all know the indications, contraindications, mechanisms, but let's go beyond that and see a stroke as a wholesome procedure at every level, at a lower level, at the district level, at the tertiary level, and at the highest level. We all will discuss all that. Okay, so before we discuss, I want to clear that this video does not contain the pathophysiology because we all are very well versed with it. And I will not make the whole video in a single sequence. There will be parts of the same video so that it is easy to access and easy to see. So we'll start the video. So basically, this deals with a lot of clinically oriented presentation because we all know what we have studied in our MBBS years. So these are more of the guidelines which has recently come up and they are very very important. They has a new definition and everything. So we will discuss all that. So let's start. It has just come in the month of December. So what are we going to discuss? We are going to discuss about the definitions, presenting feature, what are the risk factors, how could you primary prevent the stroke, how you could secondary prevent the stroke, what are the early identification markers, how you can manage the case of acute stroke within its time limit, what should a stroke unit have, what history, physical examination, and investigation you should order, what you should do in an intracerebral hemorrhage, general management, secondary prophylaxis, drugs that can be used in a non-valvular AF, then physiotherapeutic management, just one slide on it, what kind of diet should be prescribed, and the references from which all these has been taken. So there are two very important definitions, एक stroke का है and एक TIA का है. What is stroke? Stroke is the symptom, sign and symptoms which has developed rapidly, बहुत जल्दी develop हुए हैं within last 24 hours, all which can lead to death, and its origin is still unknown and the cause is other than the vascular origin. So stroke consists of two and or three important words. One, it is rapid and the signs comes within 24 hours or more than 24 hours, and it may lead to death and the cause is not vascular. Three things. Now transient ischemic attack, it's a transient attack of a neurological dysfunction caused by a focal brain, spinal cord, or retinal ischemia without acute infarction. Once the word infarction has come, it automatically becomes stroke. TIA is reversible. Stroke in most of the process in first 4.45 hours, it is reversible. But if it is more than that, it might lead some of its deficit and it does lead that. What are the presenting features of stroke and TIA? First, we will discuss TIA and then we will go to stroke. Now, in a TIA, what do you see? In TIA, we have a transient weakness. There is a weakness, paralysis of face, arm, and legs, typically on one side of the body. You may have a transient slurred speech or difficulty in understanding speech. There can be a transient blindness or there can be a double vision. There can be a curtain-like vision like amaurosis fugax. Then there can be a dizziness, there can be a balance of some coordination. These all are symptoms, but the important word here is the transient. These all things are transient. Coming to stroke, stroke is S and S for sudden. Is a sudden numbness, sudden confusion, sudden difficulty in speaking, sudden trouble in seeing from both the eyes, sudden dizziness, sudden loss of balance, sudden lack of coordination, and sudden impairment of consciousness. Everything is sudden. In this, it is transient, it is reversible. In TIA and in stroke, it is sudden and acute, and the treatment is also very sudden. So everything is sudden in stroke. What are the risk factors? These are very similar risk factors which we have for the CAD, that is non-modifiable and modifiable. Then how you can primarily prevent it? You have to be very vigilant in controlling hypertension, in controlling diabetes, obesity, any alcohol history, tobacco history, atrial fibrillations, carotid aortic stenosis, sickle cell disease, alcohol I've already discussed, and mitral stenosis. These can precipitate the stroke. So you better maintain all this in a integrated manner. Then early identification and management of stroke. So what you will do in a TI, we'll start from TI and then we'll slowly go to stroke. So TI, you have seen a patient having a transient features, give an aspirin of 150 mg and clopidogrel 300 mg loading dose and 75 mg as a maintenance dose for first 3 weeks. After 3 weeks, you can give either aspirin or clopidogrel. One is a crescendo TI. That means that stroke risk is increasing and it should be treated as being at high risk of stroke and should be assessed as soon as possible within 24 hours. When you will say it's a crescendo TIA, when there are two or more than two attacks of TIA within a week. Then this is we always say it in Western language, we have many mnemonics, but our national guidelines have given a very good mnemonic that anyone complaining of sudden problem in देखना दिखाना हाथ पैर बोल चल, किसी को एकदम से देखने में प्रॉब्लम हो रही है, बोलने में प्रॉब्लम हो रही है, चलने में प्रॉब्लम हो रही है, सोचने में प्रॉब्लम हो रही है, कॉन्शियसनेस में प्रॉब्लम हो रही है, सो यू कैन रिमेंबर बचाव, दैट इज बाजू, आवाज, चेहरा एंड वक्त. ठीक है, ये उसको किसी बाजू में वीकनेस है, उसको बोलने में दिक्कत हो रहा है, उसके चेहरे की जो सिमेट्री है वो चेंज हो रही है, या फिर ही इज अनएबल टू रिकॉग्नाइज द टाइम अराउंड हिम, इट यू सस्पेक्ट अ स्ट्रोक until unless it is proven otherwise. Bachav. Bachav of stroke, we will study how we will treat the patients. So what are our aims? First of all, the very important is to distinguish. What we have to distinguish, that whether this rapid onset is a stroke or it is a mimic of stroke. What do you mean by a mimic of stroke? Whether it is some electrolyte imbalance, whether it is some hypoxia, whether it is some sudden, road traffic accident, it's a sudden trauma. Is it a psychiatric, or is it just uh, malingering? So first of all, identify the event. So to identify the event, the clinical features are sufficient, and add on to that, we go for a radiological investigation, that is NCCT head. Why we go for NCCT head is because that helps us in ruling out is it an ischemia or it is a hemorrhage. Then ask the history, ask about the risk factor of diabetes, hypertension, tobacco, alcohol, age, is he or her taking any other medication, is he or her on any is she is on any OCP. Then in males you ask for the NSAIDs history, you ask for any family history of dyslipidemia, family history of stroke. These are very important clues. Then the complications can arise and you have to predict it before coming, okay, and then plan the appropriate treatment accordingly. Now you had the symptoms of bachav and you admitted the patient to the hospital, you have to get an urgent CT within first 20 minutes and detect the worsening and perform the urgent intervention and management. Then you evaluate and monitor for the if that patient does not go into a hemorrhage, and if it is a hemorrhage you treat it surgically, and if the patient is getting treated you have to be very careful to manage its complication before it arises, such as aspiration pneumonia. Now the patient is going to discharge, you have to plan the rehab of the patient by advising of physiotherapy, food, educate the caregivers that bed should be near the toilet and he or she should not go to the toilet alone, um, and there should be a frequent exercises plan for the patient, frequent follow-up plans for the patient. Now, if you want to establish a stroke unit in your hospital, what does the national guidelines say? 4 beds. For 4 beds, there should be 2 physicians trained in a stroke care. There should be 4 nurses, physiotherapist, and a written standard SOPs should be there on that board. Now, these physicians and doctors, I've discussed it further that there should be a neurologist, neurosurgeon, resident neurologist, resident neurosurgeon, and the doctors under. No, you have to take the history very carefully. Very, very, very important. And the most important thing is the time of onset. Why time of onset? If for example the patient रात को सो रहा था and उसके अटेंडेंट ने सोते सोते एकदम से देखा कि उसकी बाजू गिर गई, एकदम से उसकी बाजू गिर गई, तो वो टाइम उसको पता होगा कि 12 बजे गिरी, और वो हॉस्पिटल ले आया at 3 a.m. So we still have 1.5 hours to thrombolize the patient. On the contrary, patient became unconscious at night and his attendants noticed it in the morning. Then we have lost those golden hours, and now we cannot thrombolize the patient, and we have to go for the supportive therapy or the surgically endarterectomy and surgical removal of the clot. So time of onset is very important. Second, history. History, previous history of stroke, MI, seizure, trauma, surgery, bleed, pregnancy, and vegetarianism. Then, is he on some aspirin? Is he on some heparin? Is he on insulin? Then, modifiable factors का history, diabetes, hypertension, tobacco, alcohol, smoking, non-smoking. If non-smoker, any chula in the past, use of chula in the past. Then any heart disease, hyperlipidemia, migraine, recent history of headache or migraine, recent childbirth, risk of dehydration. Now, physical examination always start from airway, breathing, circulation, temperature, SpO2, BP. Now, blood pressure becomes a very important criteria in, first in assessing whether the patient could be thrombolized or not. Second, to suggest that whether there's a ischemia or a hemorrhage and how this BP will be controlled, how acutely the BP has to be taken down or not acutely the BP has to be taken down. Then any history of trauma from the eye sign, from the contusions, and any seizure history from the urinary incontinence, cut on the tongue, then petechiae, purpura, jaundice, carotid bruit, peripheral pulses, carotid auscultation, Glasgow Coma Scale, then NIHS scale. This is a long NIHS scale. Now, GCS scale, we all know, we see the eye opening, verbal and motor response. Then there we have a big NIHS scale. And then there's a history physical examination we have seen. Then every district hospital should have a CT scan availability 24/7, and these availabilities should be available in a district hospital. One is a CBC, LFT, RFT, BTCTs, lipid, blood sugar, ECG, X-ray, urine routine, HbA1c, thyroid function test, CRP, PTI-INR, and blood protein. Now, what is the immediate specific management of a ischemic stroke patient coming to you within first 4.5 hours? So it can be treated within 4.5 hours after the onset of symptoms. It should be considered for bridging IV thrombolysis. Now, IV thrombolyze, we have to thrombolize by 0.9 mg per kg infusion of alteplase or once injection of tenecteplase 0.2 to 0.25 mg per kg followed by mechanical thrombectomy if there is a occlusion of the large vessel. Now, I will discuss it in further slides. What is the dose and what is the dose should be given immediately and what dose should be given in the next 1 hour. Immediate treatment is FESH. What is this FESH? You just not, first of all, make it very clear. Stroke का management सिर्फ alteplase नहीं, it's a big treatment, and it's not just that you manage the clot. It's a lot that comes along with clot. There's a etiology behind the clot. क्यों बना वो clot? ऐसा नहीं था कि clot था बॉडी में, वो वहां जाके बन गया और पेशेंट को स्ट्रोक हो गया, ऐसा नहीं था. क्लॉट धीरे धीरे बना, किसी चीज ने उसको प्रेसिपिटेट किया उस क्लॉट को. तो वी हैव टू ऑलवेज बी वेरी केयरफुल व्हाट इज द etiology and what are the patient's another signs and symptoms. We should not ignore that. And most of the clinicians ignore the other symptom. They just thrombolize the patient and that's it. That's not it. That's just a start. And even it's not a start. We have to see a lot of things before thrombolizing the patient. And most of the times, patients and even doctors say that, okay, the thrombolysis is not available, so we cannot treat the patient. That's not true. You at least try to treat the symptoms. Yes, thrombolysis is important, no doubt, but there are a lot of other factors which also contribute to the disease etiology and the onset. So look at the patient, look at the temperature, whether he is hypothermic or hyperthermic. Then what is its swelling reflex? Is swelling and reflex present or not present? Look at the RBS, look at the BP. These are very important in first 24 hours of last noon. Well, that's why this is called SOAP, because these are very important. These are the things that we manage in the ICU. Now, uh, if this is like a summary to the whole thing which we are going to study. If there is an internal carotid or a proximal middle cerebral artery occlusion, then let's go for the combination. How the combination? You thrombolize the patient and you also aspirate using a stent retriever. Then, if there is an intra-arterial clot, in case of intra-arterial clot, that is a contraindication to IV thrombolysis. You can't thrombolize the patient, but not to a thrombectomy. You can take out this clot, extract कर सकते हो, or you can cut that area of the artery. Should be given at least 300 mg of plain aspirin and 300 mg of clopidogrel immediately after excluding the intracranial hemorrhage. Done. In case of large infarct, if it is involving whole of the brain का area, it's a large MCA infarct, aspirin may be delayed until surgery. Once the surgery has been done or the patient refuses for the surgery, aspirin has to be started. In dysphagic, why we were saying that we have to manage the swallowing? In the patients who are dysphagic, aspirin may be given through the enteral tube. Now, stroke secondary to the arterial dissection, in those cases, antiplatelet should be preferred rather than anticoagulants. In case of a embolic stroke of undetermined source, we should get a Holter scan at least at the 7th day instead of 24 to, and then you have to go for 24 to 48 hours of monitoring, but get a Holter scan once. So these are clear things. So these are the indications for IV thrombolysis. The age of the patient should be more than or equal to 18 years of age. There should be a significant neurological deficit that might lead to a long-term disability. NCCT showing no hemorrhage. Acute ischemic stroke symptoms with onset clearly less than 4.5 hours before thrombolysis will be given. After that, it will not be given. So, 4 indications: age, no hemorrhage, significant neurological deficit, and by time of onset less than 4.5 hours. Contraindications: if he has some recent intracranial or subarachnoid hemorrhage, if the area involved is more than one-third the cerebral hemisphere and they are multilobar, recent history of surgery or serious head trauma or stroke, uh, uncontrolled hypertension more than 185 by 110, presence of intracranial conditions, might it be a neoplasms, AV malformation, aneurysm, active internal bleed. Now, these are very important. This is known as bleeding diathesis, which is not limited to these, but these lab parameters are important. Platelets should not be less than 1 lakh. Uh, if he or she is on oral anticoagulants, INR should not be more than 1.7. Prothrombin time should not be more than 15 seconds. Then administration of heparin in last 40 years are with elevated APTT, and administration of low molecular weight heparin in last 24 hours. Now, let's talk about the dose of two most important drugs. One is the tenecteplase and other is the tissue plasminogen activator, alteplase. Tenecteplase is a IV bolus dose for the acute stroke patient, 0.2 to 0.25 mg per kg, maximum dose of 20 mg, and it is given in 1 to 2 minutes. CDSCO recommends 0.2 mg per kg should be given bolus within 5 seconds, within 3 hours of stroke onset. Tissue plasminogen activator should be given in two phases. One is a bolus phase, in which the 0.9 mg per kg is given bolus over 1 minute, and rest of the remaining dose is given over 1 hour. Now, after giving an infusion, the work is not over. Work has just started. We have to monitor the patient for every 15 minutes for first 2 hours, every 30 minutes for next 6 hours, every 60 minutes for next 16 hours. Now, when do we suspect an intracranial hemorrhage while a thrombolysis? When the patient has a sudden neurological deficit, when there's a new onset headache, acute hypertension, nausea or vomiting, immediately notify the medical specialist. If the BP is more than 175 by 100, avoid any kind of IM injection, avoid Follies, avoid NGs, perform venipuncture very carefully. If in any case angioedema develop, uh, make a prepared vials of IV methylpred, 125 mg, IV diphenhydramine, IV ranitidine, and if the patient is still not improving, go for intubation if there's a respiratory distress. Now, for confirmed symptomatic hemorrhage on CT, the guidelines changes. First of all, consult a neurosurgery department, get a CBC, BT, CT, PTI, INR, APTT, fibrinogen, D-dimers done. In case if fibrinogen is less than 100 mg per deciliter, then give a cryoprecipitate 0.15 units per kg. If in case of uncontrolled life-threatening bleed, give a EACA, that is aminocaproic acid, 10 gram IV in 250 cc NS over 1 hour as a last resort. This is very important that in case of intracranial hemorrhage, you have to give a EACA, and if the fibrinogen levels are less than 100 nanogram in milligram, then we have to give cryoprecipitates to the patient. Now, what are the indications of surgery in case of an ischemic stroke? Surgery in case of ischemic stroke. Still, we are discussing ischemic stroke. So, the slide is very important. What we have to do in what kind of infarct. So, from this slide till the other management, we will see in the next lecture, because this lecture was basically about the definition of stroke TIA, what will be the presenting features of TIA, all will be transient, what will be the presenting feature of stroke, everything will be sudden. How did you manage a TIA? You gave aspirin and clopidogrel. How did you see a crescendo TIA? What was crescendo TIA? Crescendo TIA was more than 3 attacks of TIA in a week. That for that case, you have to treat it like a high risk for stroke. And then coming to stroke. In stroke, what is the time duration? What is the age? What are the comorbid factors? And in which case you have to do what? For example, if the time of onset is less than 4.5 hours, you have to manage the airway, breathing, circulation. You have to manage the sugar, you have to manage electrolytes, BP, then you have to control the fever, and then you have to come for the thrombolysis therapy. We have two options in that. One is the IV thrombolysis that you do through a tenecteplase, 0.2 mg per kg over 5 seconds, bolus dose. And in case of alteplase, that is a tissue plasminogen activator, we have to give 0.9 mg per kg as a bolus. That means if a patient is of, let's say, of 90 mg, okay, for the 90 mg, 90 kg ka patient, we have to give 0.9 mg per kg IV bolus. That means 0.9 mg per kg. We divided the dose into 10% and the 90%. So the 10 mg has to be given as a IV bolus, and rest of the 80 mg has to be given an infusion in next 1 hour. While giving the infusion, we have to be very careful. We have to monitor the BP for every 15 minutes for first 2 hours, then every 30 minutes for next 6 hours, and then every 2 hourly for next 16 hours. And if the infarct is too big, as we can see in front of this slide, then we have to go for surgeries. Surgeries, intracranial hemorrhage, I will discuss it in the next lecture. Thank you.